Dibble, would you?
Okay. Good morning. I'd like to call the meeting of the Committee on Health and Human Services to order. It's Thursday, February 16th, 2023, and we have 4 bills on our agenda today, so a very full agenda. We do have a quorum present, although we won't be taking voting action on these bills. Wanted to talk for a minute about the plan for today. We do have 4 bills that relate to healthcare access and affordability. One of the key priorities for me and for many members of the committee, I believe, is to be working on legislation that will help ensure that more Minnesotans have access to affordable and comprehensive health care. Today, we are kind of setting the stage for additional work. These bills, we are giving them a hearing, but we will be laying them over. Any further action on the bill will come with additional time for people to discuss the bill contents, any changes that we bring forward. And I would appreciate, not only questions today and the time that we have to discuss the bills and the public testimony that we're going to hear, but I would also invite any further questions and things that you think about after the meeting to be sure and get in touch with me or the bill authors and discuss those ideas you have with them. It's really important to me that we are working on specific actions that will help more Minnesotans get access to high-quality health care. The bills today include measures to expand coverage to more Minnesotans through existing programs, through creation of a new public option. Another bill is to help more children stay connected to coverage, and so we have quite a variety of different ideas. We want to get them out there and have a discussion today, so I really appreciate that we will have public testimony. So I will be moving to the table to present the first 2 bills, and Senator Bolden will be chairing for that part of the meeting. So thank you.
All right, and Dr. Chamalo, you may please introduce yourself. Sorry, Senator Wiklund, proceed.
Okay. Yeah, I will introduce the bill, and then we will have Dr. Chamilo present his part of the program. And thank you. So before us, I would like to discuss Senate File 531, and this is a bill that will provide, it does a couple different things. The bill addresses one long recognized problem that we have seen improvement in during the pandemic that relates to Medicaid churn. This refers to the problem of eligible Minnesotans who cycle on and off of coverage due to bureaucracy, high mobility, small fluctuations in income, and other glitches. Churn creates instability for eligible Minnesotans, and during the pandemic, to meet federal requirements that were designed to protect individual and public health, Minnesota stopped processing renewals and stopped requiring enrollees to report changes. People who were enrolled, they stayed enrolled. This bill is meant to help ensure that we don't return to old levels of churn when the public health emergency ends. So I also have an author's amendment that I would like to have distributed at this point, and I'll continue to talk about the bill. Basically, Section 1 of the current bill and remaining contains common sense best practices to ensure communications reach enrollees and to decrease the number of eligible enrollees who are disenrolled simply for non-receipt of mail. These codify current practices of the Department of Human Services. Section 2, where the amendment makes changes, it will provide, there's kind of different categories. So it will provide 72-month continuous eligibility for children up to 6 years old, and 12-month continuous eligibility for older kids. And what we didn't get included in the bill that was introduced, which we intended to include, thank you, at all times, was to include also providing a period of 12 months of continuous eligibility for people over 21. So I would like to be able to adopt this author's amendment today so that we have that out in front of everyone who will know that that's part of the bill. As I said, it was something that we intended to include, but just did not get included. So I don't know if members have a question about that.
Madam Chair.
Senator Abler.
Thank you, and I thank you for the amendment, and it's your bill, Madam Chair, it's your amendment. I just wanted to clarify something. This has been discussed now in this committee and the Education Committee about the right of an author to have an author's amendment. And the custom is not that we don't talk about it. The custom is they get to have their amendment as a courtesy, because they could have written the bill however they would like. And so I want to thank you for explaining the amendment, and just to help people be aware that the custom is not to have it randomly put on without being explained, but that the person, as a courtesy, gets the right to their amendment, and no one's going to mess with that as a roll call or anything, but just that you get it. So thank you. And so I'll be voting in favor of your amendment to get the bill in the shape you would like. Thank you.
Right.
So Senator Wiklund offers the A1 amendment to put the bill in the shape in which she would like it. Any other questions, members? All right, seeing none, all those in favor say aye.
Aye.
All those opposed? All right, the amendment, the motion passes and the amendment is adopted. So Senator Wiklund, to your bill as amended.
Thank you very much. Now I'd like to move to, we have a presentation to talk about why this bill is so important for Minnesotans, for children. And I really appreciate having this along with our discussion today, and I will turn it over to presenting Dr. Chamilo.
Dr. Chamilo, please introduce yourself for the record and proceed.
Yes, thank you, Chair Bolden, and thank you, Senator Wiklund. My name is Dr. Nathan Chamilo. I'm a pediatrician and internist and serve as DHS's Medicaid Medical Director. I'm going to pull up my slides here. All right. So I'm happy to be here today to talk about continuous eligibility in medical assistance, how this is a step towards better health and racial equity. Since we are talking about health and racial equity, I think it's always important to ground ourselves in the role that us as a state and the Department of Human Services have had in creating inequity. And so we are working on recognizing the impact of trauma, medical abuse, and discrimination that have happened to our Black, Native, and American Indian communities of color, those who live with disabilities, and identify as LGBTQ+, that has led to distrust in medicine and social service providers, and that the work of equity and anti-racism requires that we are all actively committed to rebuilding that trust. And so this work really does align with our state's stated goals. Governor Tim Walz's very first executive order on establishing the Minnesota Council on Diversity, Equity, and Inclusion talked about all Minnesotans are provided the opportunity to lead healthy, fulfilled lives. But we know that that's not the case. We aren't yet at that goal. And so this is data from the Health Economics group at the Department of Health that is looking at the rate of uninsured in Minnesota. And while we had made some gains, in particular over the last couple of years, with continuous eligibility in relation to the public health emergency, we can see that with the expiration of the public health emergency, there is an expectation that a significant number of Minnesotans will go uninsured, and the ranges there go anywhere from around 200,000 to 300,000 Minnesotans. And we know that that risk isn't shared equally. And so their data looks like that looked at even in this time of increased coverage with a lower uninsured rate, that in the last several years, the rate and gap has widened for Minnesotans of color. As you can see, representing roughly 10% of Minnesotans of color being uninsured versus 4% statewide. And we know that we are missing opportunities to insure folks who are eligible, particularly in our state programs. And so their data has also looked at, amongst those who are uninsured, who is potentially eligible for public insurance. And you see the rate on the top line there is for all uninsured Minnesotans, with roughly 57% potentially publicly eligible. And then when you look at white Minnesotans versus Minnesotans of color and American Indians, you see that it's a much higher rate. 68% of the uninsured are potentially publicly eligible. And so this speaks to the Minnesota paradox that's been described before by Dr. Samuel Myers at the University of Minnesota, who speaks of, while we have great opportunity and outcomes for white Minnesotans, as depicted by this picture of former Governor Wendell Anderson, we know that not all Minnesotans share that same opportunity. And so it's helpful, I think, to look at how Minnesotans get health care as how Medicaid and MinnesotaCare contributes to the inequities we see and how we have an opportunity to be part of the solution. And so on the left there, you can see data from Shadak and Dr. Lynn Blewett's team that's looking at overall Minnesota healthcare coverage in 2021, and estimating that roughly 14% of Minnesotans get their coverage through Medicaid. And that's a relative undercount, they admit, because of the data they use, but that's in the range that we'd expect. And what you see on the right is their data of Minnesotans by communities of how they identify by race. And so, as you can see, Black Minnesotans, 42% get their coverage through Medicaid or MinnesotaCare. For American Indian and Alaska Native Minnesotans, is 39%. And so forth. And so we know that different communities are impacted differently when there's changes to our Medicaid and MinnesotaCare programs. And we see that there is also a difference when you look at 7-county metro and non-metro Minnesota, with, for all groups except one, an increase in percentage of Minnesotans in non-metro Minnesota who get their health care coverage through Medicaid or MinnesotaCare. So again, a geographic impact on changes we make to our program. And then there's an age impact too. Children are more likely to be covered by Medicaid. Again, as you see on the left there, roughly 32% of Minnesota children are covered by Medicaid or CHIP or MinnesotaCare. And again, a significant increase in our communities of color, American Indian, Alaska Native children, 60% get their coverage through Medicaid, with 58% of Black Minnesota children, 38.6% of Hispanic or Latino Minnesota children, and 34.6% of Asian Minnesotan children. And then for our birthing persons as well, Medicaid covers roughly 40% of births in Minnesota, covers roughly 9 out of 10 of Minnesota's Native American and American Indian birthing persons, and 8 out of 10 of our Black birthing persons in Minnesota. So we have a significant role in addressing health and racial equity, in addressing some of our worst racial inequities, which lead to our worst racial health disparities. and noting that communities impacted by those disparities and inequities are disproportionately covered by Minnesota Medicaid really calls on us to focus. And that was the focus of a report we put out last year that started in 2021 on how we could build racial equity into the walls of Minnesota Medicaid, looking at community strengths and what are Medicaid's levers. And so this report was co-created with community, highlighting both their resources, but also the impact of structural racism in our systems. And we started by focusing on the U.S.-born Black Minnesota community. As we talked about earlier, they both get a significant part of their community, get our coverage through Medicaid, as well as experiencing a lot of the health disparities from our systems. And so this was an iterative process where we met with leaders from the U.S. born Black community to talk about what are Medicaid's levers, what are some potential solutions that we should focus on to improve health and racial equity in our programs. They gave us their guidance. We took that back to our policy staff and came up with some calls to actions that we presented in community conversations. In this gray box, you can see the lived experiences of folks that showed up to our community conversations. And we incorporated all of that into a report that really sought to kind of guide our priorities, recognizing that there's many ways that we could achieve health and racial equity, but we really should be community-led in making the priorities of what we focus on. And so amongst those priorities was focusing on eligibility and enrollment. And we tried to compile both what we heard in our community conversations with what's been described in previous reports, like our deep poverty report, about what community members' experiences were with eligibility and enrollment. And they often talked about the process being confusing or complicated, or that our communication on folks' status was poor. And really wanting us to focus on how we can keep people enrolled who are eligible. And so here you can see quotes from members of the community who shared their experience in trying to maintain or gain eligibility for Medicaid. And so our first call to action was that we should improve racial equity in eligibility, enrollment, and renewal by pursuing continuous eligibility policies. And so implementing a 12-month continuous eligibility for those who are 0 to 19, as well as exploring 1115 waiver to implement 72 months of continuous eligibility for children on Medicaid up to age 6, and 2 years of continuous eligibility for all enrollees age 6 and older. And you can see the other calls to action, and be happy to come back at some time and go through those as well. But I wanted to highlight that's germane to this conversation is that of all the calls to action, the ones that community members were particularly excited about and highlighted as their top priority were those that supported continuous enrollment, in particular the 72 months continuous enrollment for children. And we know that this is actually backed up by literature. A lot of evidence that there are costs to unstable or interrupted coverage. And so individuals who have interrupted coverage are more likely to end up in the emergency room, more likely to be hospitalized, more likely to seek care for acute illnesses. And they're less likely to get access to things like medications that could keep them healthy. And we know that churn impacts communities differently. And so there's been evaluations of what's called income volatility, where a family's income might fluctuate from month to month, which based off of a state's policies might then put them eligible for some services one month and not eligible the other month. And we know this income volatility impacts households differently, with Hispanic households and Black households having higher rates of income volatility. And then we look at churn itself, which was Senator Wiklund talked about at the top. We know that Black Medicaid enrollees in the national samples were more likely than white enrollees to go off Medicaid for more than 6 months, which led to them having less likely to have regular checkups, more likely to forego health care needs, and more likely to report problems paying medical bills. And there's positive impacts of continuous coverage. And so we see when folks maintain their coverage, they're more likely to get care for those chronic illnesses, get supports they need to stay healthy and stay in the community, and that there's a cost benefit with an analysis in 2005 to 2010 showing that the administrative cost of disenrolling and re-enrolling one person within a year costs between $400 and $600. And then we see similar benefits for children in particular. So decreased coverage leads to more gaps in care for mental health, for acute illness, for dental care. And continuous coverage promotes access to to supports and cares that lead to more healthy and successful children, leads to more stability within families. And we know that this actually contributes to academic readiness, and that's particularly when you're talking about those first 6 years of life and the importance of brain development, that it is a significant period of a time to need to be important for folks to be connected to supports consistently. And so I thought it would be helpful to take a quick snapshot of the Minnesotans that MA covers that are less than 6 years of age. Since January 2020, we've seen an increase of approximately 6,285 children, or about 3.5%, that are covered by MA, for a total of 181,000. You can see the demographics by race there. And we know that when we look at where they live, 43% live in zip codes that we would classify as areas of high disadvantage by the Social Vulnerability Index. And that we know that there's a roughly 50-50 split between those that live in greater Minnesota and the 7-county metro area. And then we also want to look at what's been the impact of COVID-19 continuous eligibility policies on churn in MA. And so what you see here is amongst enrollees who received continuous coverage between July and December of 2022, when we looked at those who were able to maintain enrollment in the years 2018 and 2019, we saw that 78% were able to maintain enrollment. When we look at 2020 and 2021, we saw that increased to 94%. We're able to maintain enrollment in part due to the policies that are part of the response to the COVID-19 pandemic. And so that's a kind of raw increase of 16%, a relative increase of 20%, or 1 in 5 Minnesotans on our programs that were able to maintain coverage during the public health crisis thanks to this change in policies. And Minnesota also has an opportunity here to go from among the worst in our continuous coverage policies to among the first. And so this is a map from Georgetown University's Health Policy Institute and Center for Children and Families that it was tracking states that had enrolled, or implemented, I should say, 12-month continuous eligibility for children, which was an option that we had prior to the pandemic. And Minnesota was in the minority of states that had not yet implemented that 12-month continuous eligibility for children. Since then, several states have put forth proposals to CMS to extend continuous eligibility to 72 months for children 0 to 6 years of age. And then Oregon also including that 24 months for children and adults over 6 years of age. And so, as you can see here, Oregon is put that forward, but as well as California, New Mexico, and Washington, who are all considering expanding continuous eligibility up to 6 years of age for their children as well. And it should be noted that with the Appropriations Act at the end of 2022, it was now a federal requirement for us to implement at least 12 months continuous eligibility for children. And so when we look at Governor Tim Walz and Lieutenant Governor Peggy Flanagan's budget, we see that they called for expanding medical assistance coverage for children, so including that continuous eligibility for children under 6 up to 72 months, and then coming into alignment to have at least 12 months eligibility for children older than 6, and then extending that up through age 20. And so I really hope that the committee and our legislature helps capture this moment for change, that we learn from what we've seen with the COVID-19 pandemic of what changes have worked and helped and benefited our communities. We see clearly that our data shows that this can help reduce racial and geographic gaps in maintaining access. We've heard clearly from communities that this is among their top priorities to improve health and racial equity in our system, and that research has found that there's numerous benefits for children and Black, Native, and other communities of color in particular. And so I've been ending presentations for roughly the last year with this quote from W. Du Bois that talks about the moment we're in and how this is the accepted time, not tomorrow or some other convenient season. It's today that we can do our best and not some future day. So thank you, Chair and Committee, for having me. Thanks to my DHS colleagues for helping with this work, and thanks to the community members who participated in our putting this forward as a priority.
Thank you, Dr. Chamelo, for your presentation and for your work. Senator Wiklund, do you have comments, or would you like to move to other testifiers?
Well, I don't have other comments. I would just, I guess, say that we are connecting to other efforts that we brought forward in this committee and discussed. Yesterday, we talked about how community solutions are so important, bringing community members in to be able to propose different solutions, and that includes access to healthcare information, healthcare programs. So there's a connection there. And also, just wanted to say that in terms of getting our kids off to a great start, I think having access to high-quality early childhood education and care is another way that we can support families in these early years, and having access to, continuously have access to healthcare providers during these early years is also a great way to bring stability and positive development for all families. So, yeah, I'd be happy, actually, I'd like to, I know that you are not able to stay for the whole hearing. Do you want to take questions now, and then we can move to the other testifiers? If we could do that, that would
Certainly.
be good.
Yep. So members' questions, Senator Abler.
Well, thanks, and I'm not going to talk very long, but I just, we've discussed this situation and helping health disparities since I've been here. And I don't think every health disparity is intrinsically racist. I think some are just stuff that happens. You know, I mean, just if you define racism, then the fact that on page 10 that 60% of the Alaskan Natives have medical assistance and 16% of whites have medical assistance. That's by definition racist because it's a disparity you could predict. And it used to be good news they're on health care, you know? And so if you're looking at the health disparity outcomes, maybe the way we're doing it isn't working. As a friendly to all, and I'm not against everything you said, I'm just, you know, this eligibility thing, maybe that's going to help, but maybe the way we're doing our system isn't working. Maybe the HMO system isn't as good as it was. I've discussed at great length, like UCare has had a passion to help reach into communities, and they've gone out of their way to have buses and to find ways to make it work. And Blue Cross put forward a grant, the same thing, and they got picked over UCare on some of these matters. And Blue Cross is not as good at this. But they write a better grant thing. They're better writers. And so UCare got squeezed out and Blue Cross got to get in the door. Maybe that's part of it. You know, people that are actually really good at this who are committed to it. And just want to encourage us about that. And, you know, these eligibility things, you know, 6 years of eligibility for an infant. What if the family gets good insurance, you know, somewhere else, they get to stay eligible. This money is adding up. I just read in today's paper that the federal debt is supposed to go up $19 trillion in the next decade. $1.4 trillion this year, borrowed money. And every time I've been just as guilty trying to chase federal money. But at some point, there's not going to be any. We want to make sure the money we have is well spent. And we learned yesterday, Doctor, you were not here, that the Department of Health has a disparity in their own grant program where they're not going as well to minority groups as in our own departments. And so, I mean, as we go after this, everything isn't like a purposeful effort to cause harm. It may be accidental, there could be good intent. And so I'm with you to try to go after that. But I just caution us to make sure like what we're doing is done correctly. I've got 44 years in the healthcare side. They pay lousy rates in medical assistance. So the people who are poor and black and everything are going to go to doctors who barely are losing money on every visit. Why do we want to do that? Maybe the rates are partly to bear for the poor outcomes. And, you know, in healthcare, in my instructions to my patients, it's your responsibility to be healthy. I'm going to help you. And so how do we help people to take on, their own responsibilities for their families and mail back the forms. And I'm glad you're reaching out and giving a couple chances. There was one time a couple years ago when we decided that we were going to be told that mailing counts as notice. I'm glad and I fought against that. I said it has to be a certified letter, and actually won that argument. So there's just to help you, there's a couple sides to the coin, and this is actually more of a Rubik's Cube or something, but as we go forward, let's keep working together about how to make what we have better and to get the outcomes that you desire and I desire, that you can't tell a difference based upon a person's race, what happened to them. And anyway, so I'll leave it at that. Thank you.
Any follow-up, Dr. Shomelo?
Yeah, thanks, and thanks for the comments, Senator. I usually, when I have a little more time, to go through a definition, because I think definitions really do help ground and level set us. And I use the definition of Dr. Kamara Jones, who's a physician, PhD epidemiologist, and former president of the American Public Health Association, who defines races as a system of structuring opportunity that unfairly advantages some groups and communities, unfairly disadvantages other groups and communities, and saps the strength of the whole society through the waste of shared resources. And so I think, what you are getting at is that there are different levels of what we might define racism. Some intentional, some unintentional, have developed over generations. And I think what you laid out there are many different ways we could get to our shared goals of better opportunity and health. And I think what I haven't always seen is that the ways that we prioritize are dictated by the communities most impacted by the disparities. And so I agree that we need to do things differently, and this is what the role of the Building Racial Equity into the Walls of Minnesota Medicaid report was to have more community-led input. And they are the ones who brought forward this as a priority, and which is why I'm talking about it today. But many of those things you brought up were also shared by community members, and we do intend to address them along the way, but really trying to take the lead of, again, those communities most impacted in what we put forward here.
Senator Utke.
Thank you, Madam Chair. And some of the conversations we've been having here have touched on this a little bit. So and it was also in your slides here that when you talked about the data shows, it finally said something about geographical gaps. And to me, I've been listening to this for a number of hearings here now, and we hear about the racial stuff, and to me that, kind of helps, it divides races and highlights different things, but to me the community, the zip code, the neighborhood that these people live in probably better identifies who's suffering and needing the help, because I think in most cases it's a mixture of a lot of people, but we know that there's pockets that are really struggling, and that's kind of what these programs are targeting. So I was happy to see that geographic was finally added to it. I think that's important. It isn't just the other things that are highlighted in here with race, et cetera. But two things, and part of this is probably more for Senator Wiklund, the bill author, but these programs, medical assistance, MinnesotaCare, that we're looking at here, we always hear so much about people that are on these programs and they can't get off, basically, because we have a cliff on everything. And we want people to, if they need these programs, get what they need, but yet human nature is to progress, whether it's further education, something that gets you into the job market for training, et cetera. But when they're kind of hinging on the edge of moving out of these programs, they can't make that jump because it's all or nothing. So how can we work some of that in? And then finally, looking at this bill, there's a lot of additional spending. Do we have a fiscal note coming? Where do we stand on that, and any estimate of what this costs?
Senator Wiklund.
Thank you, Senator Utke. To your last question, yes, we will get a fiscal note. That's part of the reason I wanted to get the amendment added so that we can request the fiscal note with the actual the bill in the way that I'd like to see the cost. So we will definitely get a fiscal note. The other question about, having a cliff or a benefit cliff effect, I think it is something that we need to look into. I would say that having the ability to have continuous coverage as an adult for 12 months, I think it does allow then for people to get additional, take on additional responsibilities or have an increase in salary, a slight increase in salary, and have the stability in knowing that they're going to remain eligible and can continue to see physicians until that, excuse me, until that 12 months is over. I think that's what we are seeing, that many who are working in areas that have more fluctuations in their hourly rates, they will, their income will go up slightly and might disqualify them, and then it goes back down, and then they're qualified, but they're in the meantime disenrolled, and then that causes a lot of this churn that people reapply then, and administratively that causes more work for us as well. But I think having a sense of a 12-month period where you have coverage, I think it allows people to think more about taking on, being able to get additional hours and expand, their responsibilities. And like you say, when they are able to move off of the public programs, I think then they can do that. And I don't know if you'd have any other thoughts.
Dr. Chumalo?
Yep, yes, Chair, thanks. Yeah, I mean, I think there's been a lot of evidence with the expansion through the Affordable Care Act of seeing decrease in bankruptcies. I think the stability of having health care over that time also may allow folks to think about, maybe now's the time I've built up a little bit that I can start my own business or see other opportunities ahead of them. We've certainly mentioned in the slides that with those gaps in insurance, people do still end up having health emergencies and incur significant medical bills. And so this continuous coverage does, I think, help give folks a better path to the kind of life they want to build, and avoiding some of those pitfalls in our current healthcare system.
Senator Wiklund?
Madam Chair, and then I would also put a plug in for one of the additional bills that we'll talk about is, if we have a MinnesotaCare, we have also, something that's a MinnesotaCare public option, then people do have a way to move into different, from, one program, the, MA program into MinnesotaCare, and beyond that to, a public option. So I think that is something that we're looking at and we hope to improve on.
Okay. Senator Ecke, you good?
Thank you, Madam Chair. And that opens up a whole new can of worms when you talk about the expansions, and we can wait with most of that till we get to the Senate File 49. But it's also a balancing act with our providers because, as Senator Abler already commented, the reimbursement rate on the programs we're talking about here do not cover the costs for our providers. And if we send a lot more to their door, and we want people to have coverage, but when we encourage that payment plan, we're going to lose providers. So I'll wait for the rest of that until we get to the next bill. But it's a concerning thought, as if we're looking at expansion, is how do we continue to provide those services when we don't pay for them? So thank you.
All right, I'm going to move to Senator Abler, and then we're going to move to testifiers, as we have a lot of people we want to hear from today.
And I'll be brief, but we haven't had a chance to chat, Dr. Chumalo, if I said that right. And like you're the latest batter to get into the batter's box and tackle this in a public way, and I pray you succeed. A lot of us have been up to bat and tried and didn't get as far as we thought. And so in your role, you're in a position to look at things from the overall view as a policy advisor and actually implementing policies that are within the scope of what you're allowed to do and coming to us with new ideas. And to the whole Medicaid idea, there is a working model that I'm really excited about, which is county-based, where they wrap around the social services into the medical services, and they actually pay decent rates to the clinicians. They include almost all the providers. And and I think you might want to just look at the disparities in the counties where they're doing that, where they're able to wrap this around, compared to the medical silo and the social services silo and like that. And so medical assistance is a silo. And so if you want to achieve success, I encourage you to look at that. And maybe Minnesota's been on the wrong track with going with the silo approach, but a more integrated approach will get us where we want. And I wish you the best. I wasn't expecting the dialogue to start out how it said. That's what you got from me in the beginning. But I think it makes a lot of sense, and I'm here to be part of the solution if I can be. Thank you.
All right, thank you again, Dr. Chamalo, for your work and for the discussion this morning. Clearly, the racial disparities we see in healthcare and other aspects here in Minnesota are real and persistent, and will continue to come up in our work in this committee, and we'll continue to do the work to address them, so thank you. And with that, we will move to testifiers. And I will just say that we have a lot of folks that want to testify today, which is wonderful. However, we are limited by time, so I am going to ask that each testifier limit your comments to 2 minutes. We will be timing you, so when you hear the timer, please try to wrap up your current thought. And we want to be able to hear from as many people as possible. So first, we will have Ann Quincy, then Sue Abderholden, and then Laura LaCroix-Delhoun. So you all may come forward. And Ms. Quincy, please introduce yourself for the record and proceed.
Thank you. Madam Chair and committee members, my name is Ann Quincy. I am the supervising attorney at Legal Aid of Minneapolis's Benefits Unit. Our office represents low-income residents of Hennepin County in civil cases, and I specialize in public benefits like cash assistance and public health care programs, like our Medicaid program, medical assistance, and MinnesotaCare. Our clients are your enrollees. Senate File 531 proposes to reduce churn for Minnesota's Medicaid participants. And you heard from Dr. Chamalo and Senator Wiklund about what churn is, so I won't repeat that. But it's always important to keep people who are eligible and in need of this health care coverage enrolled, and never more than now. The federal public health emergency required Minnesota and all states to provide continuous coverage during the pandemic. And this gave us a picture of what MA enrollment would look like without churn. What we saw is that new applications dropped each month, indicating that before the pandemic, we were dropping people from the program who were eligible, often for things that are very common for legal aid's clients, like returned mail in the middle of their plan year, because a family became homeless or is highly mobile, or they worked a short-term job, only to have them have to re-enroll the next time they needed urgent medical care. Nina is a good example of one of my clients where the churn that the public health emergency protections prevented really helped. Nina called Legal Aid in December of this past year from an emergency family shelter. She and her teenage daughter had lost their apartment due to paperwork issues with the family's benefits. The shelter was a physical lifeline, but both mom and daughter were really stressed. The real lifeline was the individual and group mental health therapy this family was engaged in, really committed to, and relying on. Imagine adding to this family's dire circumstances.
Ms. Quincy, please wrap up your thought.
Okay.
Thank you.
Adding to this family's dire circumstances the impending loss of coverage because mail was sent to their old address. Senate File 531 will save the state in administrative costs and uncompensated care, but
Thank you, Ms.
most
Quincy.
importantly, it will help the enrollees to get consistent care.
Thank you, Ms. Quincy. Sue Abderholden, please introduce yourself and proceed.
Thank you, Madam Chair. Members, Sue Abderholden, Executive Director of NAMI Minnesota, and we strongly support Senate File 531. What we saw prior to the pandemic is a lot of what I would call churn, people going off of MA and then several months later coming back on. And churning costs money. There are additional administrative costs, often higher medical expenses due to pent-up demand for health and mental health care. And when people are not accessing the health care or mental health care they need, they may require more or not less services because their condition worsened. A report from the Kaiser Family Foundation found that children and adults without disabilities had the highest churn rates. 11.2% of full benefit children and 12.1% of adults were disenrolled and then subsequently re-enrolled within 1 year. I know others are going to talk about early childhood, but I do want to mention for children 6 to 18, we see access to mental health services to be important since 50% of all mental illnesses emerge by the age of 14. Keeping this age group on for at least a year will help ensure better continuous coverage and access to mental health care. The adults are often working with fluctuating income and hours. It's important to remember that nationally, about 30% of adults who gain coverage under Medicaid expansion have a mental illness or substance use disorder. And Medicaid is the largest payee of mental health services. There was a study of Medicaid enrollment patterns for people with serious mental illnesses, and they found that only 38% of the participants, only 38%, were continuously enrolled during the study period. People with schizophrenia were 29% more likely to churn than those with depression. Loss of coverage disrupts treatment. And why might people with serious mental illness experience more disruption? Housing instability, so the paperwork gets sent to the wrong address and is not forwarded. The symptoms of a mental illness may also make it hard to understand the forms, to have the additional information readily available to verify eligibility, or the paperwork simply becomes overwhelming and never gets filled out. We know that having insurance is one predictor of people being able to access mental health care. Thus, it's critical that we do everything possible to help people re-enroll, including following up on returned mail or when forms are not returned. Thank you.
Thank you, Ms. Abder-Holden. Ms. LaCroix-Dalloun, please introduce yourself and proceed.
Good morning, Madam Chair, members of the committee. My name is Laura LaCroix-Dalloun, and I'm here today on behalf of the Minnesota Prenatal to 3 Coalition. In order to move us along, I just really want to make sure as we talk about healthcare coverage that we also talk about the importance of early brain development. 80% of the brain is developed in those first 3 years of life, which actually sets the stage for one's future health, mental health, and well-being overall. According to the U.S. Department of Human Services, a child has at least 6 well-baby visits in the first year of life, and an additional 7 more visits by the time they turn 4. When children have access to these services early on, they have better health outcomes later. Public investments in continuous medical assistance eligibility for children up to age 6, coupled with the 12-month eligibility postpartum work through Medicaid that you passed in 2021, will really start to ensure that babies and young children are moving forward and meeting their health needs. Disruptions in healthcare coverage leads to more emergency room visits for young children, which will decrease costs if we have this continuous coverage. And as you heard Dr. Chumalo say, our Black, Indigenous, and children of color are disproportionately on Medicaid, as well as families in greater Minnesota. This policy can create stability for families. We know families receiving public benefits struggle and worry about accepting small pay increases. So you mentioned the cliff effect of these public benefits. It's heartbreaking to hear families say they have to turn down a 10-cent or a 25-cent pay raise that would lead their family towards long-term stability, because if they accept it, they would reach that cliff and drop off the assistance rates. So please join me today in passing Senate File 531 as amended.
Excellent timing, thank you. All right, having had some discussion on this bill and knowing that we will lay it over and that will come back to us again later, any final thoughts? Senator Wiklund.
No, thank you. I think the testifiers have reinforced the points that I wanted to make, and I do hope that we continue the discussion about what effective measures are to increase the health and well-being for Minnesotans.
Madam Chair.
All right. Senator Abler.
Thanks, and I don't know if Senator Utke was about to ask the same question, but the eligibility for under 6 continuously for 6 years. I'm sure you've thought through that the family gets a really good job and they're covered by work. Is there going to be some, by another system, are they going to then not be eligible anymore and drop off, at least with that caveat?
Senator Wiklund.
The bill and the application that would be needed to the federal government to get the waiver, I mean, what it states is that the individual's eligibility may be terminated earlier, and then it gives different conditions that are in place, you know, and one of it isn't that the family's income goes up. I mean, the point of this is that families who are in this situation, they tend to experience fluctuations in their income. It may fluctuate to a point where they're not eligible, but I think that having the opportunity for their kids to have stable medical coverage over that period of time is a higher, you know, is a priority and worth that effort. So,
Madam Chair.
Senator Abler.
I just think you might want to look into that some more. I mean, you have a teen mother who's, her and her child are going to be covered. The child may be adopted. I mean, there's all kinds of things that can happen. The under 26, they may actually be covered under their parents' insurance. You know, and I just think you want to think it through. I think there's a lot of aspiration in the proposals coming. The money to fund this, we've made choices in the past because there was a finite amount of money. We're in a surplus time now. I've sat through a $6 billion deficit, and it was not fun. And if we push every dollar that we can into every program without even thinking about ways to exit people who legitimately don't even need it anymore, I'm just encouraging you about that. I'm not trying to be mean, but we just got to be prudent. And we're in a surplus now. That's all projected. So I'll leave it at there. Thank you.
Senator Wiklund.
Madam Chair, I definitely will take your thoughts into consideration. We'll look at that, and maybe we can find some additional data to help us understand how many people actually, with their kids over that period of time, are moving into a significantly higher income category, and we can take a look at that. Thanks.
All right. And with that, Senate File 531 will be laid over. Senator Ecke.
Thank you, Madam Chair. And Senator Wiklund, as you're going to be checking on some of these things going forward, a question about this includes some continuous coverage for adults over 18 years old. Does the federal government currently allow for that, or is that a waivered process, or what do you see now, or at least if that's investigated as we move forward, and we'll have an answer when this comes back?
Senator Wiklund.
Thank you, Madam Chair. Senator Utke, the current, I believe that we will definitely have to apply for a waiver to put this in place for kids and for adults. I think that the federal government recently passed the continuous coverage requirement for 12 months eligibility for the older children. So, you know, that may not require a federal waiver, but I mean, the other parts, we will be applying for that. Oregon has received permission to do this already, and was mentioned in Dr. Chomela's presentation. There are other states who are actively pursuing this right now.
Senator Ecke. Okay. All right, and with that, Senate File 531 will be laid over for possible inclusion. And we will move to Senate File 49. Senator Wiklund.
Thank you, Madam Chair. Senate File 49 is the MinnesotaCare Public Option Bill. We are proposing, or with the purpose of this bill is to increase healthcare coverage and affordability by giving more Minnesotans the option to choose the simple, comprehensive, trusted coverage of MinnesotaCare. In Minnesota, as we have discussed, I believe that everyone deserves access to health care, no matter our race, income, age, or zip code. But too many Minnesotans today lack an affordable choice for quality health coverage that actually covers the care they need. This results in uninsurance, underinsurance, and uncompensated care, as well as stress and hardship. People are purchasing insurance plans, but then they aren't able to afford to use them because of the cost sharing and out-of-pocket costs. So this proposal puts forward a MinnesotaCare public option, which would extend the public health insurance option to individuals above the current cutoff of 200% of federal poverty level at an extended sliding premium scale. It also creates a small business public option, so small employers can contribute to quality coverage for their employees. And the bill also removes the prohibition on undocumented Minnesotans participating in MinnesotaCare, ensuring undocumented Minnesotans can contribute towards coverage at the same levels of other families. Under current state law, undocumented Minnesotans are only eligible for emergency medical assistance, which only covers limited emergency-related care. The exclusion of undocumented Minnesotans from Medicaid, MinnesotaCare, and MinSure is a crisis, and it's a driving force of uninsurance, uncompensated care, and health inequities in our state. Federal immigration reform is stalled, but we can ensure that those who live and work in our state have access to the care they need and deserve. I won't spend as much time talking about that. We do have a separate bill that's going to be presented by Senator Morrison about this coverage as well. The bill directs the Department of Human Services to work with other agencies and CMS to seek a federal waiver and ensure that we receive a pass-through of federal dollars available to subsidize health coverage for this population. And this bill includes language to offer a path toward delivery transformation, greater racial and geographic equity, and potentially cost savings for our state. While MinnesotaCare is a public program, it is currently operated through contracts with managed care organizations who are paid capitated rates. They in turn pay providers rates they negotiate. The bill requests a report by January 1st of 2026, evaluating our current delivery system against other options in terms of impact on provider participation, coordination of care, increasing health, and reducing racial disparities. I do have a summary of the bill that I could go over, but I think in the interest of time, we do have a large number of testifiers. Maybe we will go through testifiers, and then we can come back to specific questions about the bill.
Very good. Yes, we do have a number of testifiers. So just as a reminder, if you hear the timer, please wrap up your current thought, testifiers. We want to hear from as many people as possible. So we will start with a testifier via Zoom, Barb Keith. Please turn on your video and unmute yourself. Introduce yourself for the record and proceed.
Hello, my name is Barb Keith. I'm a retired public health nurse. I've worked in community nursing for 25 years, and I'm also a leader in Isaiah, Minnesota. Many of the people I've served have had affordable public health insurance with good benefits. That is, they're served by Medicare and medical assistance. MinnesotaCare has also been a godsend to many low-income Minnesotans with low copays, low deductibles, and good benefits. Today, I would like to tell you the story of one of my friends who is currently on MinnesotaCare. She really wants you to listen to her story and has asked me to share it on her behalf. She is self-employed with a 5-year-old business. She and her husband qualified for MinnesotaCare early in their marriage. Prior to getting on MinnesotaCare, my friend described herself as, quote, not able to function on my own or in society, unquote, due to her mental health. Since getting on MinnesotaCare, she has had routine mental health care and tells me that she feels, quote, more like herself than she has for many years. She and her husband have recently divorced. She had to take on a second job to make ends meet. She tells me that after taking on a second job, she made about $30,000 last year. Annual income guidelines for MinnesotaCare for a household of one is $27,180. She now makes $235 per month, too much to qualify for MinnesotaCare. Thus far, she has not had to renew her MinnesotaCare coverage due to the pandemic. But now, as emergency policies expire, her eligibility will be reviewed. When that happens, she will be forced into the private market. She knows that it will be much more expensive to get good insurance. She tells me that if she were put in this situation, she would have no choice but to add to her credit card debt to meet all of her monthly expenses. Because she's been getting her life back on track, she's been hopeful. That hope will vanish. All Minnesotans, not just people who have good employer insurance, should have access to affordable health care. It's very important for my friend and many others like her and to our society as a whole that MinnesotaCare public option is passed into law this year. Thank you.
Thank you, Ms. Keith. The next testifier is Luke Breen. After that will be Chris Sheeman. Mr. Breen, please introduce yourself and proceed.
Thank you so much, Madam Chair, members of the committee. My name is Luke Breen. I'm a lifelong Minnesotan, grew up out in Benson, Minnesota, currently reside in Minneapolis. My wife and I own Perennial Cycle, which is a bike shop in uptown Minneapolis. This April will be our 30th year in business. Perennial Cycle has 8 to 14 hardworking employees. As a small business owner, my wife and I have taken on a lot of challenges. A lot of them are by our choice, by going into business on our own. Some of these challenges are bigger than others. Healthcare seems to be one of the challenges that is simply too big for our small business to overcome. It is normal for my own family's health insurance to have a deductible in the range of $10,000 to $14,000 over the last 20 years. Up until the Affordable Care Act, that insurance did not even include an annual physical. Thanks to the MinSure Marketplace, we are able to get our own my own family's insurance through that, and that's working out quite well for us. The business that I own is just simply too small. It's falling into a crack where we do not profit enough to be able to buy insurance for our employees. And it makes it hard to keep staff. And then the staff falls into even a little bit deeper a crack in that they make too much to get MinnesotaCare, and yet all they're able to get is some basic insurance, which really isn't health care to cover themselves. So as soon as they are falling off of their parents' plans, they're tending to have to go look for a job that's in the corporate world. This combination just makes it pretty hard to run the business. I do believe the MinnesotaCare option would be extremely beneficial to businesses like my own, and I really hope that you'll consider it. Thank you.
Thank you, Mr. Breen. Next, we'll hear from Chris Sheeman. After that will be Dr. Lita Barud. Mr. Sheeman, please introduce yourself and proceed.
Good morning, Madam Chair, committee members. My name is Chris Schneeman. I'm an independent agent serving and advocating for individual and small employers throughout the state of Minnesota. I also have served the state in the past on healthcare financing task force that was established by Governor Dayton. I'm here today representing the Agents Coalition, which includes the 4 professional agent associations in Minnesota, which are the Minnesota Association of Health Underwriters, the National Association of Insurance and Financial Advisors, the Professional Insurance Agents, and the Independent Insurance Agency agents. Collectively, we represent over 54,000 licensed insurance agents throughout Minnesota. The Agents Coalition opposes Senate File 49, the MinnesotaCare public option, because it creates an unfair government-sponsored competitor to the Minnesota-based private sector plans. It's unfair for 4 significant reasons. First, the government has no capital requirements, unlike private insurers who must charge rates adequate to keep them solvent. Government will use the taxpayers as a backstop in the event that they don't charge enough premium or that they pay out more claims than they expect. 2, private insurance carriers also pay the cost of compliance. There are numerous regulations and consumer protections, but MinnesotaCare does not have to comply with these laws. 3, private plans also pay a number of taxes that the state program does not have to pay. 4, we've heard it, claims are the biggest part of premiums. The most significant advantage of the public option is the fact that the MinnesotaCare pays your local hospitals and clinics below their cost. So the additional cost gets shifted to the private sector. To understand the magnitude of that difference, legislators just need to review the recently released 2021 report from the Minnesota Community Measurement, which shows that commercial plans pay 207% of what Medicare pays, over twice as much. There is also a 2016 study by Milliman that was commissioned by DHS, indicating that the gap between MinnesotaCare and on-exchange individual policies was about 50%. These facts alone account for the price advantage that is used to sell MinnesotaCare as a cheaper alternative. I don't think any objective observer would consider this fair competition.
Thank you, Mr. Schneeman.
Final comment. My clients, your constituents, will quickly find that the public option would soon be called the only option. And I don't think that's a true competitive market. Thank you.
Thank you for your testimony. Next, Dr. Lita Brood. After that will be Dan Andreessen. Dr. Brood, please introduce yourself and proceed.
Madam Chair and members of the committee, thank you. I am Alita Borud, a physician and member of the Land Stewardship Project. I cared for many farmers who presented to hospital with advanced cancers coming in too late for a cure. Why? I learned that because of the MinnesotaCare cliff that Senator Utke spoke to, many farmers can pay up to $40,000 a year in deductibles and premiums before they can actually access a penny of care. Farmers can't afford this. We're losing family farms to medical debt. And many families are forced to take off-farm jobs just for health care benefits. But as we know, small business owners face this same high cost of insurance. And in fact, I met a woman from the small town of Casson who closed her salon for a job in Rochester just for health insurance. You know, we cannot talk about supporting rural main streets or family farms without fixing this. SF 49 is a fix. Reinsurance is not. In fact, our own MDH chart books show that while premiums on MNsure have stabilized, insurance companies have simply cost shifted to enrollees in the form of high deductibles and copays. And rural people with average incomes below the state median are disproportionately on high deductible plans or uninsured. High out-of-pocket costs are causing people to prevent seeking the care they need until they end up with a crisis in their local ER. Then rural hospitals are left with debt that people can't pay, and it is well known that this is a big source of the debt that rural hospitals are carrying and contributing to their financial troubles. So if you believe everyone needs care regardless of their zip code, please support SF 49. Thank you so much.
Thank you, Dr. Brood. Next, we'll hear from Dan Andreessen. After that, Peter Nelson. Mr. Andreessen, please introduce yourself and proceed.
Thank you, Madam Chair, members of the committee. My name is Dan Andreessen with the Minnesota Council of Health Plans, trade association for Minnesota's nonprofit insurers. We appreciate the meetings we've had so far with Chair Wiklund on this bill. Look forward to continuing these conversations as we share concerns regarding the affordability of health care. We do support some provisions in the bill, including expanding MinnesotaCare eligibility to undocumented residents. And the council has been a longtime supporter of the MinnesotaCare program in its current form and the benefits it provides to those just outside of eligibility for medical assistance. However, before the state embarks on expanding eligibility to all Minnesotans, there needs to be a thorough study of such a proposal before we even consider implementation. We appreciate the inclusion of study languages in the bill. We do think there's some areas that need to be expanded, but we definitely need to study these areas in particular. This includes contracting with independent entity to perform the actual modeling and estimate enrollments and premiums and cost-sharing changes in all markets and how this interacts with federal tax credits. Looking at impacts to the commercial market, including market stability, adverse selection, and cost shifting. And impacts to providers, including reimbursement rates and if participation is going to be required. And if providers refuse to take MinnesotaCare enrollees, what will be the impact to enrollees' access to care? Keep in mind that hospitals are required to treat every person who comes in through their door. Individual providers don't have that same requirement. We also need to look at the coverage and utilization differences between commercial plans and MinnesotaCare to make sure people know what products they're buying. Lastly, we should not go into this process just assuming that a MinnesotaCare buy-in is the only solution to this situation. If we're looking to find new ways to reform the fully insured market, we should look at we should study what other states are doing, and also look at what would be the impact of increasing individual market subsidies. Minnesota is the only one of 2 states with a basic health plan, and no other state has attempted a proposal such as this. Thank you.
Thank you, Mr. Andreessen. Next, we'll hear from Peter Nelson. After that, Cindy Vanderpool. Mr. Nelson, please introduce yourself and proceed.
Hi, Madam Chair, members of the committee, my name is Peter Nelson, and I'm a Senior Policy Fellow with Center of the American Experiment. And we're all here today to talk about a public option because the Affordable Care Act really didn't deliver full affordable care for every Minnesotan. I think we all understand that. We experienced substantial premium increases after the Affordable Care Act was put in place. From 2014 to 2017, average premiums went up by 119%. That was the largest premium increase in the nation. And that led us to reinsurance. We implemented a reinsurance program in 2018, and I worked at the Centers for Medicare and Medicaid Services from 2017 to 2021 and worked on these reinsurance programs and helped basically bring these reinsurance programs to 15 other states. And Minnesota's experience through an evaluation was a remarkable success. It lowered premiums by up to 36% for a benchmark plan. And this evaluation from the RAND Corporation shows that it kept 82,000 people in the market. This public option would basically abandon that success and move to a different approach that would be very disruptive in the market space. And part of the reason is because it relies on compelling providers to accept lower rates through our state laws. And if you compel these lower rates, you are going to ultimately lead to either lower quality within our healthcare system, you're going to lead to higher private pay rates, or you're going to lead to closures of facilities because they can't sustain lower rates. And instead, I think we should build on this reinsurance program to the extent there are affordability issues. We've seen other reinsurance programs across the country who have taken more targeted approaches to reinsurance. So when there are regional variations that make it more expensive for insurance in certain parts of the state, they can adjust for that. The state of Georgia did that, the state of Colorado did that, and this is always done on a bipartisan basis in these other states. And it is a powerful tool. We can build on it, we can improve on it. That is the direction we should be moving, and I appreciate your time.
Thank you, Mr. Nelson. Next, we'll hear from Cindy Vanderpool. After that, Kate Lynch. Ms. Vanderpool, please introduce yourself and proceed.
Good morning, Madam Chair and members of the committee. My name is Cindy Vanderpool, and I am here as a farmer and a strong supporter of SF 49, an established MinnesotaCare public option. My family and I own and operate a small business and farm named Pastures of Plenty in Kirkhoven, Minnesota. We are an organic crop farmer, and we direct market all the pork, beef, and eggs that we raise on our farm to families across the state of Minnesota. As farmers, without access to affordable health care, we are always waiting for that other shoe to drop. In 2021, the shoe dropped hard. I was diagnosed with stage 1 breast cancer. I underwent surgery as soon as something was open and did 33 rounds of radiation treatment. I am doing well now. Thankfully, we had insurance, MinnesotaCare. If we didn't have that coverage, I don't know where we would have been with my medical bills. They were up over $100,000. And as a farmer, every dollar matters. But like every year, we get our taxes done, and we wonder if this is the year that we go without health insurance. As a child, my family owned a flower shop of my 36 years, for 36 years of my life. And then we didn't have health insurance, and we prayed every day that no one would get sick or hurt. Now, small family farm businesses have to compete with large businesses for employees. Do you know what the first thing that those small businesses or farmers are asked? What kind of health insurance do you have? What kind of coverage can I get with you? Health insurance should never be something that is always in the front of a small business's small business owner's mind, but it should be what sorry. The things they should be thinking about is a great job that they are doing as a small business owner or farmer to keep rural communities going. Thank you so much.
Thank you for your testimony, Ms. Vanderpool. Next, we'll hear from Kate Lynch. After that, Dr. Bob Koshnick. Ms. Lynch, please introduce yourself and proceed.
Vice Chair Bolden and members of the committee, my name is Kate Lynch. I work as an LPN at Health Partners. I live in Roseville. I'm here to testify on behalf of my union, SEIU Healthcare Minnesota in Iowa. Currently, too many of our patients are forced to buy private health insurance, high-cost plans with heavy cost sharing. All too often, caregivers like me watch our patients delay or skip necessary medical care because they cannot afford the high out-of-pocket expenses. I work in pediatrics and family medicine. Every day, people call in about serious health issues, and often we will recommend that they come to the clinic so we can better diagnose or treat the issue. Every day, a few will respond, I can't afford the copay, or my deductible is too high. If this bill passes, I would have fewer of those calls. I'm not just here as a caregiver, I'm here as a concerned mother. I have 2 adult sons, Martin and Jack, ages 24 and 21. Currently, they are both covered on my health insurance plan, but they will soon age off my plan, and I worry they won't have good insurance. My son, Martin, works as a mechanic, and he is already starting to have knee problems. I constantly remind him to get treatment now while he's on my plan because we don't know what his insurance would be like in the future. I worry that, like many people his age, he would get a bronze plan on MinnesotaCare. He would be tempted to skip care to save money. Worse, he might have a serious health care problem that either cripples him financially or even worse, that he can't afford to treat. The fear is very real to me. Another member of our executive board at SEIU, James Holt Jr., had a son, Alex Smith. When Alex aged off his parents' health insurance plan, he started rationing his insulin and died within days. This bill will mean parents like me can sleep a little easier. Thank you, and please vote yes to Senate File 49.
Thank you, Ms. Lynch. Dr. Bob Koshnick, please introduce yourself and proceed.
Thank you for the opportunity to discuss something I feel very strongly about. I've written 2 books in the last 3 years on. I'm a retired family physician. I'm presently chair of the Minnesota Medical Association Policy Committee. I'm speaking on my own behalf. I speak against the state getting involved in being a healthcare insurance company and the use of third-party payers, including managed care organizations and HMOs. I speak for the state working to empower patients. The state can empower patients in 3 ways. The states could set up a first dollar coverage plan, accounts similar to Indiana's Power accounts that they've had since 2008 for Medicaid. They fund $2,500 for Medicaid patients to have Power accounts. I would have this available to everybody. It would be like HSAs, but it would be for first coverage. Middle income could be subsidized. I've got this article that appeared in the January issue of Minnesota Medicine describes it in more detail. The second thing is the state could encourage DPC by enacting enabling legislation. Just look it up, Google model DPC legislation. DPC dramatically decreases the use of emergency departments and also hospitalization. It reduces costs and it has very high satisfaction. Minnesota's behind the curve on DPC. The third thing is the state can encourage defined contribution plans rather than defined benefit plans, which leads to overuse. HSAs, high deductible health plans, health reimbursement accounts, individual coverage health reimbursement accounts are all examples of that. So anyway, if anybody's interested in the book, I'll give you a copy.
Thank you, Dr. Koshnick. All right, members, we will move to questions and discussion. Senator Utke.
Thank you, Madam Chair. Senator Wiklund, as the author, with what we're hearing, and we've already had some previous discussions in the first bill, what do you see as, if this bill was to go into law, what do you see as the impact on our current individual market?
Senator Wiklund.
Thank you, Senator Udke. I think that that is something that has to be considered in the evaluation that we're going to propose in this bill. We do want to see that a delivery transformation study is performed, and it will evaluate our current system against other options. And it will include, assessing the impact on the current market, our current individual market. It will consider provider reimbursement rates and the impact that it would have on that, and providers being able to participate. So I think that that is something that we will be considering in this evaluation as we move forward. And what we want is to move towards a goal where the best outcomes are happening in terms of, people's health, care management, racial equity, the provider compensation, and cost effectiveness. And so, we have a lot of things that will be looked at as the bill moves forward.
Senator Ecke.
Thank you, Madam Chair. And thank you, Senator Wiklund. And you made a comment there that kind of leads into some of my other questions. But when you talked about provider reimbursements increasing, and we currently are sitting at about 1.5 million people on MA and MinnesotaCare. After the reevaluations and stuff that will start here in a couple months, if we get back to the so-called normal level of maybe 1.1, 1.2, that's a lot of people still on these public plans. And if we're going to increase those reimbursement rates, which is what it would take to keep the providers in business, I see an awfully huge expense. And so as you move forward with this, it's going to be interesting to see what those numbers are, because I would think this is going to be extremely expensive under those terms. And maybe I'll let you respond there before I go to the next one, because otherwise we get too far into it.
Senator Wiklund.
Well, I think that the work needs to be done to do that evaluation. I think we also need to keep in mind that there will be a sliding scale, a premium scale that's involved and required for people to be buying into the option too. So, we have those factors to consider, along with, what are appropriate provider reimbursement rates.
Senator Ecke.
Thank you, Madam Chair. And some of the things that have been covered were good comments, but the individual market serves our small business owners, it serves our farmers, and of course individuals that fall into that market that don't get health insurance with their employer. It's a small pool, but an extremely important pool. And if we take more of those out, that pool gets smaller, but we know that the more we put onto the public plans, public pay plans, the more, the commercial insurance absorbs more of those costs. And it's even going to drive those rates higher. And we talk about challenges already, particularly in the rural areas, but it's not always rural areas. We hear about metro hospitals probably suffering some of the same thing, but in rural, we're typically smaller hospitals and providers. But a reason that they're on the edge now is that, the hospital debt is already, I could say, at its max. I mean, they can't handle anymore because of the payer mix. We're already seeing they're serving more people on public pay plans than they can afford to. And to me, this just drives this in the wrong direction, because we know how important their service is to our communities where we're at. We want people to have health care. And to me, if we start driving those people out of business, it doesn't matter what these numbers are, because if you don't have the provider, you don't have any health care at all anyhow. So it's that balancing act, and you know, I hope as our conversations continue that somehow we can keep that in mind, because you know, from where I sit, I just see nothing but bad news in this bill, and I'm hoping that we can, as we go forward, somehow provide health care to everyone who's out there and, you know, wants it, but at the same time be able to keep our providers in business. And I think that's it's walking a fine line, and it's going to be a challenge, but I guess the conversations will continue, so thank you.
Any response, Senator Wiklund?
Madam Chair, yes, I mean, I definitely think that the provider reimbursement rates are a big consideration. I would say, though, about in terms of the individual market, you know, I think that today we see a lot of Minnesotans that are in the individual market, that they're paying for plans that are not, that are mostly high deductible plans that aren't providing people access to real usable coverage. You heard the testimony that if people have a plan, but they have to pay so much out of pocket that they can't really afford to go in and use the care, that isn't really acceptable either. So I think that this proposal provides another option for people. I think it's a way to increase competition in the market, and I think that it will be set up in a way that provides meaningful coverage to people and will be an option for them to choose. So, thank you.
Senator Radke?
I thought of one more thing that, and just for clarification, you know, there's the MinnesotaCare buy-in for small business owners, et cetera, but in the individual market, is there a cap on the income level where at some point they max out and are no longer eligible, or does it include everybody and it goes as high as, it could be a millionaire and still buy into MinnesotaCare?
Senator Wiklund?
Madam Chair, Senator Radke, this bill does not include a cap. I think that we also have to keep in mind that the sliding fee scale needs to be set up, and the premium scale, so that's a consideration, you know, how that would be set up for people whose incomes are higher. I also, I just wanted to make another comment about our current status, or our current state. You know, we are putting a lot of money into the reinsurance program. That's significant state subsidies of that that go into that market, and we need to consider, is that adding as much value as what we could propose and could move forward with a public option.
Follow-up, Senator Radke? Okay. Senator Abler?
Well, thank you. And you have 4 bills up today, and this bill actually could have consumed the whole time, and I'm not going to consume a lot of time, but and I'm not going to repeat what Senator Utke said or anybody, but the innovation that I've been trying to do, as I've been in the batter's box and struck out so many times trying to make a difference. The good doctor has a good idea: more direct primary care. How do we do that? And there's been a few other people in the past who talked about that, mostly doctors who actually live in the world, that this actually has to work. You know, I think a lot of us have developed a taste for good coffee over the years, and I never drink instant. I would just probably reject it altogether. But this proposal here is really simply instant coffee. It's the rates, if you need dental care, which is actually covered under this proposal, good luck finding a dentist who will take you. I've had people that are patients that need dental care. I've called up friends of mine and say, would you please consider taking this person? And they often say no, because they just can't afford the rates. Talk to the psychologists and the mental health providers under these rates in MinnesotaCare, and they can't stay open. And, you know, there's the rant, it's always, cost shifts to the commercial. No, it actually cost shifts to the provider. because there's not enough commercial left to go around and in all the networks and the fee structures that are built into there. And so as you erode the margins of providers, it doesn't mean they're not getting rich. It means they're not going to take these patients. It means the hospitals are actually going to go broke in greater Minnesota and even in the metro. So the uncompensated care is improved, but there's a $10,000 cap. And so the people with serious conditions, the hospitals, I suppose, have to eat that if they're a provider. And it's important to remember, what are we telling people? And the bronze plans costing so much money. 12 years ago, I told you so. I said this about this ACA thing. The best benefit of the ACA was it added people to the ranks of medical assistants that were single adults or uninsured, and some families. It handled pre-existing conditions, which everybody wanted to handle. I carried the bill for up to 26 myself in Minnesota. But then also what happened is a lot of the good plans that were out there that were very affordable that Minnesota was known for, and we had lower rates in the part of our budget. We were 12% in our budget for health costs. One of the envy of the country. That all went away with this improvement. And so now we're bearing with the effects. And I'm not here to bash it, but I'm just telling you, a lot of us said, be careful what you ask for. And so now we spent a ton of money to create a system that people can't afford to buy. A farmer paying $40,000 for a health plan is horrible. And that's the cliffs that happen on this. And so it's driven people into more and more creative ways to try to work around it. And so, as I suggested to the good doctor, we need to look at how we really do our health care and what are we getting for the money. And does all the interventions really matter? And people want everything. Taking away the cost sharing makes people ask the question, well, then it's free. Whoever made up the deal that $50 gets you to a hospital really did a disservice to everybody, because a hospital only costs $50,000 for $30,000 worth of care. At the end of the day, I believe the current number is around $15,000 per capita in the country is what it costs to get health care. Somebody has to pay. And if you're setting up a plan where it's the instant coffee version of what it might cost, somebody's going to pay. The governor in his budget took $1.5 billion out of the Healthcare Access Fund, one of the Minnesota miracles that we put the 2% in to buy MinnesotaCare for people, and put it on the backs of the clinicians and on the health rates, which ironically is going to make those rates blink back up to 1.8, further burdening even the cash side, where people try to be creative about that. And so I just want to caution us here. Be careful what we're trying to do here as we build more and more of our market on this kind of program. And I am as sympathetic to the plight of people not having coverage as anybody. I see it every day. And I see what they don't do, and I see that they don't follow through. But be careful of that, and I'll just leave it at that. I respect Senator Wiklund, where you're trying to go, and I see the humanity in this. But I'm just hope people realize when they buy this deal that they're really getting instant coffee. Thank you.
Response, Senator Wiklund? And maybe final thoughts for the bill?
Yeah, if there are other questions. If there aren't any other questions, I'll just give some other summary thoughts so we can move on to the other two bills that we have on the agenda. I just want to point out, I think this bill, while I will definitely keep working, we have a number of advocates, stakeholders, the government agencies, working with the other body. We're all very, very interested in coming forward with a final bill that is not only solves the problems that we've brought forward today to indicate why we think this is such a crisis, but also is something that is implementable and is something that takes into consideration the factors that Senator Abler lets you raise. The transition does include, creating a report with how the plan could be implemented, and it does include the considerations of ensuring sufficient provider participation and estimating the state costs that would be related to this. It requires the description of the proposed premium scale and how to ensure affordable premiums across the income spectrum. There also is included in the report that's to be brought forward comparing service delivery models, does include a statement that the alternative models must be included or may be included, and they're not limited to those included in the bill, but some alternatives are given as to expanding the use of integrated health partnerships or delivering care under fee-for-service through a primary care case management system. So I think we are trying to include ideas that are not, that do take into consideration some of the factors that you're raising, and we want people to be able to access preventive health care. We think that that's a way to save money, you know, in our systems. So we have been funding the reinsurance program in an attempt to bring down premiums in the individual market. But we know that over half of Minnesotans enrolled in health insurance through MinnesotaCare are enrolled in bronze plans, whose average deductibles were $6,000 to $7,000 per person in 2020. We have federal dollars and state dollars going into subsidies, but this coverage is not delivering health care that people can afford to use. So I think we have a responsibility to enact sustainable solutions for people and small businesses in the state, and to recognize that affordability is not just about the premiums. So my goal is to keep working on this diligently over the next few weeks and to come up with a proposal that we can have a future discussion on in this committee and move forward with this session. So thank you.
Thank you, Senator Wiklund, for your work on this bill and moving forward. So with that, we will lay Senate File 49 over for possible inclusion. And I will hand the gavel back over to Chair Wiklund for the next bill, which will be Senate File 896, presented by Senator Morrison.
Thank you, Senator Morrison, for presenting Senate File 896 today for Senator Mann, who wasn't able to be here. So please proceed with your presentation.
Thank you, Madam Chair. Madam Chair, members, thank you for the opportunity to present Senate File 896 in Senator Mann's absence. It is both a standalone and a subset of Chair Wiklund's bill that we just talked about. Senate File 896, or the MinnesotaCare Inclusion Act, removes the prohibition on undocumented Minnesotans participating in MinnesotaCare, ensuring undocumented Minnesotans can contribute toward coverage at the same levels as other families. Under current state law, undocumented Minnesotans are only eligible for emergency medical assistance, which only covers limited emergency-related care. They can go to federally qualified health centers for some care, but those are not available across the state and are not able to provide the specialty care many people need to live healthy lives. The exclusion of undocumented Minnesotans from Medicaid MinnesotaCare is a crisis. It's a driving force of uninsurance, uncompensated care, and health inequities in our state. And it impacts a group of people who disproportionately work in jobs like agriculture, meatpacking, grocery, manufacturing, security, construction and janitorial services, and caregiving in Minnesota, jobs considered essential during the pandemic. As physicians, Dr. Mann and I, the lead author of this bill, and we kind of jostled because we both wanted to carry this bill, but Dr. Mann and her family are much more recent immigrants to Minnesota than my family and I are, so we agreed that it was more appropriate that she be the chief author. But we understand the inhumanity and the threat to public health that excluding people from basic health care coverage poses. And we're proud to author this bill together. Federal immigration reform is stalled, but here in Minnesota, we can ensure that those who live and work in our state have access to the care they need, and we can make our state healthier and safer for everyone. So with that, Madam Chair, I'm happy to take questions and have further conversation.
Thank you, Senator Morrison. I think we'll move to the testifiers we have here. And we have, in person, we have Angela Bowles-Edwards. If you could please come to the table. And then the second testifier is Maria Maldonado.
Thank you.
Welcome to the committee. Please state your name for the record and begin your testimony.
Thank you, Chair Wiklund, members of the committee. My name is Angela Bowles-Edwards, and I work for the Epilepsy Foundation of Minnesota, providing support, connection, and education to those impacted by epilepsy in the East Metro, as well as Spanish-speaking families across the state. I'm here today to share the story of 10-year-old Sophia and her family, whose names I've changed for anonymity. Sophia has epilepsy and experiences full-body convulsive seizures. In addition to daily medications and regular checkups, Sophia sometimes needs emergency care for her seizures. Standard medical advice is to call 911 if a seizure lasts longer than 5 minutes, because long seizures increase the risk of permanent brain damage or death. Because Sophia's family is still awaiting approval for an immigrant visa, she has no insurance. Under current law, her family does not qualify for MinnesotaCare or any other insurance options. While Charity Care covers some of her doctor's appointments and medications, her family has no coverage for ambulance rides or emergency room visits. Sophia's mom shared that Sophia recently had a 30-minute seizure. As the minutes ticked by, she feared both for Sophia's life and for her family's well-being when the ambulance bill arrived. She loves her daughter, and she called 911, and the hospital was able to get Sophia's seizure under control. Now, when she needs to be focused on helping Sophia recover, she's facing the stress of an enormous medical bill that she cannot pay. The Epilepsy Foundation of Minnesota urges you to support Senate File 896, which would allow families like Sophia's to access coverage for life-saving care under MinnesotaCare. Thank you for your time.
Thank you very much for your testimony, and if you could sign in on the sheet, I'd appreciate that. Next testifier, Maria Maldonado. Please come up to the table. Welcome to the committee. Please state your name for the record and begin your testimony.
Hi, good morning, and I'm just going to be translating for Maria.
Thank you.
Buenos días.
And if you can pull the microphone, just be very close to the microphone. Thank you.
Buenos días, miembro del comité y chair Melissa Wiklund. Mi nombre es María Maldonado. He vivido en San Clau por 21 años y soy líder de fe y justicia.
Good morning, members of the committee and Chair Wiklund. My name is Maria Maldonado. I have lived in St. Cloud for 21 years, and I'm a leader with Fe and Justicia en Unidos, Minnesota.
En agosto del 2022 se me abrió una vena en mi pie izquierdo y ya que no cuento con un seguro médico, yo me estaba haciendo las curas en mi casa, pero estoy preocupada porque la herida constantemente vuelve a abrirse y mi pie aún no sana por completo.
In August 2022, a vein broke in my left foot, and since I don't have health insurance, I was taking care of it at home. But now I'm worried because the wound constantly reopens and my foot still hasn't healed completely.
El 1 de febrero decido ir con un doctor y le pregunté si me puede referir con un especialista. El doctor me dice que sí era necesario, pero que necesito un seguro de salud para poder asistir a esas consultas, ya que es muy costoso.
On February 1st, I decided to go with a doctor, and I asked him if he could refer me to a specialist. And the doctor told me that it was necessary for me to see a specialist because of my condition, but I needed health insurance to be able to make that appointment, and it's very, very expensive.
Entonces, estoy aquí el día de hoy para resaltar la importancia de tener un seguro de salud. Yo soy esposa y madre de 4 hijos y soy diabética. Tengo miedo de que la herida se vaya a infectar y no quiero perder mi pie porque eso afectaría mi capacidad de trabajar y necesito brindar el soporte de mi familia. Necesito, pero un seguro médico. No puedo asistir a mis consultas médicas regularmente.
So I'm here today to highlight the importance of having health insurance. I'm a wife and a mother of 4 kids, but I'm also a diabetic, and I'm afraid that the wound will become infected, and I don't want to lose my foot because that will affect my ability to work, and I need to support my family. But without health insurance, I cannot attend my appointments regularly or see a specialist.
Por favor, apoyen esta propuesta hacia la inclusión de los inmigrantes en MinnesotaCare, la propuesta 896, ya que cambiará la vida de miles de personas que se encuentran en una situación similar a la mía. Gracias.
And this is the final part. Please support MinnesotaCare eligibility for undocumented non-citizens, Senate File 896, because this will make a life-changing difference for me and thousands of Minnesotans. Thank you.
Thank you very much. Thank you for coming and sharing your testimony with us today. We have the last testifier is, and I apologize if I mispronounce your name, Vina Iyer. Welcome to the committee, and please state your name for the record and begin.
Thank you, Chair. The pronunciation was perfect. It's Vina Iyer, and I am the Executive Director of the Immigrant Law Center of Minnesota. Chair Wiklund, Lead Utke, Senator Morrison, members. The Immigrant Law Center of Minnesota is a legal services organization with Minnesota offices in Austin, Moorhead, St. Paul, and Worthington. Each day, we have the privilege of working with immigrants and refugees across Minnesota who are feeding our communities, taking care of our elderly, and raising the next generation of Minnesotans. But they cannot access affordable, quality health care because they lack the official immigration paperwork which confirms what we all know. They are Minnesotans and they are Americans. SF 896 addresses this issue by expanding MinnesotaCare to cover Minnesotans regardless of immigration and citizenship status. The need for this legislation was laid bare during the pandemic. The Census Bureau reported that 69% of undocumented workers worked in frontline jobs considered essential during COVID-19. It is appalling, but not surprising, that among the foreign-born Latinx community in Minnesota, COVID-19 mortality was therefore concentrated in relatively younger, prime working age men. Immigrant workers were more likely to be exposed to COVID-19, but less likely to seek early treatment. In short, they and their families had no way to pay for care, and they only sought out that care when it became a life and death matter. It was often too late. By passing SF 896, you have an opportunity to improve the health and prosperity of all Minnesotans. Parents of young U.S. citizen children would have access to preventative care. Employees would have access to treatment of medical conditions that are not eligible for emergency medical coverage treatment. And recent arrivals would have access to affordable primary care and copays for mental health visits. Sickness and disease do not differentiate based on citizenship status. We Minnesotans go to school together, work together, and as I observe on a monthly basis as a mother of 2 young children, we get sick together. When all Minnesotans can get preventative care to avoid getting sick and early diagnosis and treatment when we do, everyone is healthier. Our state should therefore adopt SF 896. Thank you.
Thank you. Thank you, Ms. Iyer. Members, any questions or comments about the bill? I think we have one more bill and several testifiers. I'd like to be able to have them testify since they did attend the hearing today, but I don't also want to cut off all discussion or questions. So do any members have questions? Senator Radke.
Thank you, Madam Chair. And I just, for some crazy reason, have to add this. But, you know, I hear the challenges and such, but we're a country of laws. We have laws and a procedure for these people to follow. How do we help them through that versus just moving them to the front of the line for health care? I mean, we should be looking at the full picture. So that's my only comment is we do have laws that we all are supposed to live by and abide by. And I think we need to look further than just a health care bill.
Madam Chair.
Senator Morrison.
Madam Chair, thank you, and thank you, Senator Udke. And I agree with you completely. Unfortunately, our federal immigration quagmire is just that. It's completely stuck in gridlock in Washington. In the meantime, we have Minnesotans living here, and at a time when the population of Minnesota is stagnating or declining, we have workforce shortages in every sector. I would think that we would be doing everything possible to make Minnesota the best place to live and work, and I think that is a piece of this puzzle.
Thank you. Any other members? No? Oh, Senator Bolden.
Just very briefly, Madam Chair, I just want to thank you for bringing this bill. Healthcare is a human right, and we all do better. We are all healthier when everyone in our community is able to get healthcare and be healthy. So thank you for bringing this bill.
Thank you. Thank you for presenting the bill. We will request a fiscal note and be discussing it further. I think it really does make sense from the standpoint of having people access health care when they need it before conditions worsen and be able to live healthier lives in our communities. So thank you for bringing the bill.
Thank you, Madam Chair and members.
With that, we will move to our last bill on the agenda is Senate File 404, and Senator Bolden is presenting. We'll go over a few minutes. We will wrap up by 10:45 so that we do have several people here to testify, so we'd like to get through that. So Senator Bolden, please proceed.
Thank you, Madam Chair, and thank you, committee members. Also want to thank Senator Mann for her work on this bill. I am happy to fill in for her to present it. Also, we'll note that this is a bipartisan bill, and thank you to Senator Abler for signing on to this. And so this is a bill about health care and coverage, certainly, but it's also a bill about fairness and choice. Currently, people enrolled in medical assistance receive services under either a managed care system or a fee-for-service system. There are specific criteria to be on the fee-for-service system, such as certification of a disability, SED-targeted case management, cost-effective primary insurance, or adoption from foster care system. Currently, HMOs and county-based purchasing plans contract with DHS to provide services, with plans receiving a capitated payment per enrollee. In fee-for-service, healthcare providers bill the state for the services they provide to medical assistance enrollees. Under this bill, DHS must provide all MA enrollees to the opportunity to opt out of the enrollment in managed care and instead receive services under the fee-for-service based on their choice. This is a bill designed to be an opt-out and provide a choice for members. Choice allows people to choose what makes sense for their needs. Having the freedom to choose is what works best for them. Managed care plans offer a product to Minnesotans on medical assistance, but if that product is not meeting members' needs, this bill allows them the option, the choice, to choose a different product. So in lieu of time, I'll maybe stop there. We do have some testifiers as well.
Thank you. Thank you for that. We will move to testifiers. On Zoom, we do have Idil Abdul And I will say we need to have everybody conform to the 2-minute limit so we can get through all 6 of the people that we have signed up. So thank you. And please introduce yourself for the record.
Yes, good. Thank you so much, Madam Chair. Good morning, Madam Chair and members of the committee. My name is Aidel Abdul. I'm a Somali autism mom advocate. I'm also a provider. I co-own an autism clinic. First, I want to thank Dr. Nathan Chamelo for his iconic report on the state of U.S. Black-born Minnesotans. In that report, Dr. Chamelo stated majority of Black Minnesotans have MCOs for health coverage. He also stated that there's a dire racial health disparity. I totally understand the fatigue associated with racial health disparities. So let's stop talking about it and start doing something about it. The first option to decrease and eliminate racial disparity is giving low-income Minnesotans the option and the freedom to choose their health care. This legislation is about having options, not restricting choices and freedom. Everyone deserves the right to make their own decision about health care. The Somali woman who is going through the domestic abuse first goes out to my heart. But if the MCO helped her coordinate services, then she can stay where she's at. By the same token, patients who need services provided by fee-for-service, they too shall have the ability and the freedom to choose their health care. You know what makes this country is the ability to have options and choices. We cannot, in good conscience, take this option from low-income Minnesotans. If we do, what does that say about us? Madam Chair, earlier you stated more Minnesotans getting quality health care is important to you. That is important to me as a Black woman. That's exactly what Senate File 404 is about, giving Minnesotans the opportunity to get quality health care so that they choose for themselves and their family. Thank you so much for supporting this bill. I so appreciate your time. I talked fast and I timed myself. I'm 1 minute and 50 seconds.
Thank you very much. Yes, thank you. That was very efficient. Next, we will move to Diane Peterson. And then after Diane will be Dan Andreessen.
Madam Chair, I know there is a Minnesotan of color another Minnesotan of color to testify for this bill. I would like to have him testify before I testify. Mr. Jamal?
We should have time for both. I mean, if
could I have him testify first, please?
Mr. Jamal? Welcome to the committee. Please state your name and proceed with your testimony.
Thank you very much, Madam Chair. My name is Omar Jamal. I'm longtime resident in state of St. Paul, an activist and member of the Somali community. And I would like here to bring a couple of points to your attention. And it's just that this bill, SF 404, to my understanding, is way overdue bill. And if you consider the Medicare, traditional Medicare has the Medicare Advantage, and also if you look at the HMOs and all these organizations, never ask Medicare Advantage to be forced into their plans. But however, medical assistance have also, like Medicare, prepaid medical assistance where the state a while ago filed a waiver 1115 to force clients into their businesses. And this experiment, the funny thing is about that, the data of this experiment is secret, trade secret. We cannot ask them how they're conducting the experiments. And even if you ask them, it's a trade secret, nobody will tell you. And I would like to also tell those county-based purchasing and HMOs, if their product is good, they shouldn't be worrying about that. If we didn't have a problem, we wouldn't be sitting here talking about this right now. If it's broken, don't fix it. So the issue is to give us a choice to make up our own decision. I don't think so you will think that we are stupid enough not to make up our mind. It's all about making a choice. of what's best for our health. And that's what we're asking. It is the basic value, a traditional American value, which is a freedom. Give people a freedom to choose. And HMOs, county-based purchasing groups, if their product is good, they shouldn't worry about anything. We will stay loyal to them. But if it's not good, just give us the chance to opt out and choose what's best for me, my children, my family, and anybody else. So thank you very much.
Thank you for your testimony. Mr. Andreessen? And
Madam Chair, members of the committee, again, Dan Andreessen with the Minnesota Council of Health Plans. Many of our members are MCOs within the Medicaid program. The state went to a Medicaid managed care program 40 years ago because of problems within the Medicaid program. And they went to this program because of the coordination of care that MCOs can bring to Medicaid enrollees. And care coordination means serving the entire person. It's not just paying claims. It's helping them arrange transportation to doctor's visits, helping them schedule those visits, and some examples of those are in your packets in the fact sheet. Now, building health equity and addressing social determinants of health is something that's woven through all of these care coordination models that our MCOs use. In fact, managed care and MCO procurement is one policy lever that you can use to ensure accountability towards progress towards these requirements. And care coordination is really kind of the main difference between managed care and fee-for-service. Coverage benefits that's between the two are fairly identical, and MCOs are required to provide all medical necessary health services that are covered under the contracts with DHS. Also keep in mind that fee-for-service is not an unrestricted open network. Fee-for-service enrollees can only receive care from in-network providers, and services outside of that network is not covered. So the option, like was just mentioned, the option has been to opt out of managed care is currently available. And we do question if this is expanded, who would be the entity to help kind of educate enrollees to make that choice? And if they do make a choice and are not happy with it, what would be the process from then? Would they be able to switch back to managed care? And we just want to be mindful about folks kind of going back and forth between the two systems. And lastly, as you've all heard, CMS, counties, and MCOs will be pretty busy over the next year with Medicaid redetermination. We just question if this is the right time to pursue this. Thank you.
thank you. Thank you for your testimony. Ms. Peterson, would you like to provide your testimony? And then after that, we'll hear from Phil Griffin, and then our last testifier is Rayanna Buchholz.
Yes, thank you, Chair Wiklund,
And
for this
please
opportunity.
state your name for the record.
My
Thank
name
you.
is Diane J. Peterson. I live in St. Paul. I'm a leader with Health Policy Advocates, which is behind 12 of the testimonies that were published online and that are in your packets today. The legislature's name for the bill refers to the state granting permission to medical assistance enrollees to opt out of managed care, whereas our freedom to choose name for this bill reveals that it will restore a right patients previously enjoyed, choosing doctors and treatments without compelled supervision by corporate managers in managed care organization. Years ago, the state got a 1115 waiver from the federal government to experiment on medical assistance patients by putting them in managed care organizations to see if such a system would cost the state less than letting them freely choose their healthcare providers. 1.3 million Minnesotans from the Department of Human Services online data show that they are currently receiving health care from managed care corporations. They're still being experimented on, but without reliable proof that such coercion saves taxpayer money. At the same time, the state does not subject several thousand medical assistance patients to such an experiment. They are free to choose the traditional old-fashioned medical assistance plan known as fee-for-service. No corporation interferes in the fee-for-service patient's choice of doctors and treatments. This unequal treatment of the few, about 200,000 Minnesotans, versus the many, 1.3 million, is unfair. It's discriminatory. As a taxpayer and citizen, I object to the state maintaining a privileged system of the freedom to choose fee-for-service alongside a non-privileged system of compelled experimentation operated by managed care organizations on 1.3 million Minnesotans. End the the coercion, because for patients who like managed care supervision, they will be free to keep choosing that product. And for those who do not like the corporate product, restore their freedom to choose the traditional fee-for-service version of medical assistance. I'm also pleased to announce that a much larger organization than mine, Healthcare for All Minnesota, has endorsed this bill. Thank you.
Thank you. Mr. Griffith?
Thank you, Madam Chair, members of the committee.
Last testifier, Ryan Wiklund, could come to the table. So, thank you. Please proceed.
Thank you, Madam Chair, members of the committee, Senator Bolden. Phil Griffin, representing the Minnesota County-based purchasing plans. We're concerned about Senate File 404's intent, and we believe that it inadvertently would harm the access to public care programs. Senate File 404 would disrupt continuity of care and management by allowing members to opt out. I will be very brief today. I can go on. Mr. Andreasen has talked to you about a number of things, but we believe that county-based purchasing plans have done an excellent job of coordinating care, making sure that our people who are enrolled with us get immunizations and other needed services for county-based plans, have non-medical emergency transportation and dental care access. And I would just say to those that have testified before you today that the freedom to choose is there if you have providers that are willing to participate in the fee-for-service program. You've seen what's happened with dental access over the last few years and tried time and time and time again to fix those problems. The reason we moved to managed care in the 1980s under the PMAP program was because you could not find physicians in Hennepin and Ramsey County or in other counties that were willing to take patients that were on medical assistance. We'd urge you to reconsider whether this is really a freedom to choose or a freedom not to choose. Thank you for the time today, and we urge you to reconsider passing this bill.
Thank you. Thanks for your testimony. And please introduce yourself and proceed with your testimony.
Thank you so much, Chair Wiklund and members of the committee. My name is Rihanna Buckles, and I am the Legislative and Coalitions Director for Americans for Prosperity here in Minnesota. AFP advocates for bottom-up policy solutions that empower individuals to pursue options that best fit their needs. To ensure affordable and accessible healthcare options, we believe in an open market approach where variety compels competition and packages that fit each individual's unique needs. Healthcare is personal, and one size rarely fits all. We at AFP maintain that Minnesotans expect and deserve choices, and that's why I'm pleased to offer our support of Senate File 404, which would give low-income Minnesotans more choice and control over their healthcare. We appreciate the expansion of choice and access without diminishing quality of care or driving up costs, and this is what makes good public policy. This bill is a great example of what we at AFP consider a personal option in healthcare. And that means removing barriers between patients and the medical professionals that they trust. By letting low-income Medicaid enrollees opt out of restrictive HMOs and go to any willing doctor or facility that accepts Medicaid, the bill takes a small but important step toward giving all Minnesota families the kind of market-based, high-quality health care that they deserve. We applaud Senators Mann and Abler for proposing this bipartisan common sense measure and thank the committee for taking up this market-friendly legislation. We are very pleased to support this bill, and we look forward to helping the committee pass more bills like this in the future. That said, I did also submit a letter with extensive comments regarding our concerns with Senate File 49. I invite you to review it as it details our concerns. However, we also do offer an alternative solution, which is a personal option that we believe encourages transparency and competition. AFP Minnesota stands ready to help work toward collaborative solutions in healthcare, and I appreciate your time and look forward to pursuing positive public policies. Thank you.
Thank you very much for your testimony. Members, Senator Abler.
Well, thanks, and I'm actually happy to be a co-author. I would call this the Competition and Medical Assistance Act, freedom, whatever you want to call it. It seems to me that they have a limited amount of choices, and actually very often the HMOs will limit providers who actually want to be in the networks, and this way if you happen to like a clinician, you could pick it. But I don't know if any well-run, truly engaged HMO would lose one client to this if they did what they say they do, which is to coordinate their care and show their passion. I think two examples of groups like that would be UCare and the county-based purchasing. I'd be surprised if anybody leaves those plans. And the other ones, if they feel the pressure, then they ought to compete and do a good job for their clients. And that's what I see in this, and that's what I like about it. Thank you, Madam Chair.
Thank you for providing that. Any other members have comments about the bill? Senator Bolden, do you have any final thoughts?
Thank you, members, for supporting the bill. This is about choice, and agree that if folks are happy with their plan, they will keep it, and it just offers a choice. So thank you.
All right, well, thank you. This bill will be laid over. We will continue to discuss and bring people back for discussion if we do bring the bill back up for discussion. So thank you for everybody's time today. I appreciate all of the thought that went into testimony, and please let us know if you have questions, concerns, or would like to provide additional information. And with that, seeing no other business before the committee is adjourned.